Nysa Therapy Incorporated presents Healing Personality Disorders. Course number 1, Integration. Preview.
It is ethically and clinically appropriate to seek supervision or consultation before using any new technique in your practice of psychotherapy. Please contact us at nysatherapy.com if you would like to receive guidance from our highly experienced consultants.
Here is Dr. Stephen Diggs, Nysa Therapy founder and director.
Welcome, everybody. My name is Steve Diggs, and I am the director and founder of Nysa Therapy. And I want to welcome all of you who are watching, because this course is for psychologists like me, psychiatrists, nurses, people who have personality disorder, family members. It's for all of those people. But mostly, it's for master's level therapists. Why is that so? First of all, master's level therapists do most of the therapy. If you look throughout our country, and in other countries too, you will see that social workers, licensed marriage and family therapists, licensed professional counselors, they do a huge amount of the therapy, way more than psychologists and psychiatrists or any of those other professions do. And you need someone who's talking to you because you do most of the therapy. And that's what we want to do. We want to talk to you because you're doing most of the therapy. Second, I've spent a long time teaching master's level therapists, and one of the things I've learned is that most of you do not like a lot of theory. You don't like or want me to go on and on and on about Sigmund Freud and Otto Kernberg and Marsha Linehan. You don't want that. You want to get to the brass tacks of what we're trying to do. And in a way, the metaphor I like to think of is that I am like an architect, and I've developed a whole big architectural plan that has to go to the county. You don't want to see that. You're a contractor. You want to see the blueprint. You want me to hand you a blueprint and say, here's how to build this house. And that's what our course is designed to do. It's designed to hand you a blueprint without a lot of theory that says, here's how to do therapy, because you do most of it. And as you'll see later on, you're also the best people to be doing most of it, because you're the most talented at therapy, more talented than me, certainly. So, what you want me, your teacher, to do is just say it. And this is a part of the legend of Nysa Therapy, is the moment when one of our therapists who was first learning Nysa Therapy with me, and I was talking on and on about all this theory, and she said, would you please just say it? Master's level therapist, extremely talented. Kate, you'll meet her later. And she didn't want all that talk. So I turned to her and I just said it, and she said, thank you. And this course, our attitude was born out of that. So, that's what I'm going to try and do, is just say it. Now, in this preview, you will find everything that comes in course number 1, Integration, and I'm going to say it in only a few words. Following this is a very lengthy course with 5 different lessons that are very in-depth. But that's not what this is. This is a preview of this. This is a coming attractions thing. And after you've watched this preview, you can take what you've learned here and go into the rest of this lengthy course. And that's fine. That's a very good thing to do. But if you want to, you can skip ahead to other courses on our techniques, courses on treating on borderline personality. You can jump ahead if you want to, and some people will want to do that. That's absolutely okay. Take this preview, go into the rest of course number 1, Integration, or take this preview and jump ahead to whatever it is you want to learn. It's all interchangeable. Okay. The first thing I want to tell you about the Nysa Therapy in this preview is that Nysa Therapy is heavily involved in integration. And what we do is we integrate many therapies into a single therapy, Nysa Therapy. It's like a beautiful hand-woven blanket. And all the different therapies are the strands of thread that go together and are woven together. DBT, psychoanalysis, strategic therapy, experiential therapy, object relations theory, all woven together into something that works much better because we take the best of each therapy and put it in combination with the other therapies. Now, we actually integrate about 20 different therapies into Nysa Therapy. Yeah, it's big, and it's one of the things that we really believe in. We think it makes Nysa Therapy good. But most of our integrations concern 4 basic therapies. The first is relational therapy. The second is exceptional therapy. This comes from solution-focused therapy. Next is the idea that the personality comes in parts. And this comes from many traditions, but we use object relations mostly, interpersonal therapy, and transactional analysis. And finally is the idea of the self. And there are many therapies that focus on the idea of the self. Jungian therapy, self-psychology, modern-day psychoanalytic psychotherapy, all focus on that. So we're going to teach you all of these 4 combinations right now, very briefly, and in the later courses, if you want them more in depth, you can go there. Okay, let's start with relational therapy. What is relational therapy about when we distill it down to its core, when we bring it all the way down? It's about the idea that it is emotional connection that heals, not ideas. It is the connection you make with your patient emotionally that heals them, not some brilliant idea you have about why they do the things they do. Now, ideas are important to us, but that's not what heals. It is that connection. That comes from relational therapy. For example, TH stands for therapist. You can say, you have trouble trusting. You can say that to your patient. That's no good. Like a patient doesn't know they have trouble trusting. They already know that. That's no surprise to them. They were annihilated in their childhoods. The people they were supposed to trust didn't come through for them. Of course they have trouble trusting. Now you can up your game and say, you have trouble trusting because you were abused in childhood. Not much better. It acknowledges the abuse and validates the abuse, which may be important to that patient. But again, it's an idea they know. They know that they have trouble trusting because they were abused in childhood. Or you can say, I'm brokenhearted that you have trouble trusting because you were abused in childhood. I'm brokenhearted. And this works because it creates an emotional connection to the patient about the problem they're dealing with, right? Now, emotional connection can also hurt the patient. If your needs get tangled in the emotional connection, that can hurt the patient. Your needs, your emotional needs, do not have a place in therapy because this is about the patient. So, for example, you can say, the patient can tell you, I'm having trouble trusting you. And your feelings might get hurt because you've worked really hard to gain their trust. And you say to them, and you need them to appreciate you. So you say, boy, you're not making much progress, are you? Because you're kind of hurt and a little angry that they're not trusting you after all you've done to gain their trust. Now they trust you less. And that's because your need to be appreciated got in the way of their needs. How do we avoid hurting the patient? We do it with attuning, a core principle of relational therapy. And attuning simply means paying attention to the patient's feelings through connection to them. Mostly nonverbal, but you're going to attend to those emotions. You're going to track, you're going to pay attention. What is this person feeling now? What just happened? I said something, they leaned back a little bit, they looked down. What's happening right now? I'm really paying attention to the way they respond. So for example, the patient says, I'm having trouble trusting you. And you attune and you sense that something happened when their father visited last week. Now this is just an intuition you're having. But when that patient says that and looks away, something in you says, I've got a hunch. Something happened. A whole lot of therapy is hunches, intuitions, educated guesses. You've got to make them quick, act on them, see if they work. If they don't, you throw them out. And you go with your next idea, your next hunch, your next feeling, your next intuition. You remember that earlier in the session, they didn't want to talk about the visit. Right? I don't want to talk about when my dad came to visit me. I don't want to talk about that. So you say, okay, I've got to do more to help you trust me. That's my bad. Now, you might even think that the reason they're acting that way is because of the visit of their father. But you've still got to say, I've got to do more to trust you. That's my bad, because you want to reach the point where they trust you enough that even if something goes wrong in their life, they're going to want to tell you about it. So you've got to keep doing more. That's an honest thing to say, and that builds the emotional connection, doesn't it, to say that? But then you say, but I'm still curious about your father's visit. Are you sure there's nothing for us to talk about? And the patient pauses for a minute and says, well, and comes forward with what happened. He came again. He can't help it. He puts me down. He's ashamed of me. He says that all the time. And I got hurt. And now we see that this patient was hurt and communicating that to you, but you did not let your feelings get involved in that moment. Instead, you stayed caring and attuned. And here's a lovely image of attunement, isn't it? Little girl giving her mom some flowers. Her mom needed those flowers, and she went out and got them. And maybe the mom didn't say, I need those flowers, but the little girl knew. The next thing you do to build emotional connection is share your own feelings. It is the second part of making connection, along with attuning to the patient's feelings. You attune to your feelings when you're doing therapy, but they're your feelings about the patient. Not your feelings about your wife or your daughter coming to visit or anything like that. It's your feelings about this patient. Then you share your feelings with the patient using an I statement. For example, I'm brokenhearted that you have trouble trusting because you were abused in childhood. You say I. Now, in a lot of master's degree programs and internships, they tell you not to use that word. It's too personal. That you should speak more from a distant place, more as a knowledgeable helper, a skilled and knowledgeable helper. But what a lot of people in the relational revolution are learning is it is the personal experience that causes change, not the distant idea. So we want you to use the word I. This works because it creates an emotional connection about the problem, and the therapist is sharing their feelings with an I message. Now, What happens when you don't use I messages? You kind of look like a know-it-all. When you speak as an authority, it is difficult to connect with somebody, right? If I say, oh, I really know what I'm talking about because I'm a psychotherapy trainer, and here's what I know, and you should listen to me because I'm an authority. I mean, you're going to listen because I might have some good ideas. But if I say, I do this, and I found it really works for me because of this, this, and this, well, you're going to say, okay, well, I might do that too. It gets more personal. And then what you'll do is you'll take in whatever idea I have, and you'll make it fit you and your vocabulary and the kind of person you are. And that's when therapy works, because the more personal you are when you're in the therapeutic relationship, the more therapy works. And the more I give you ideas that you can make your own and use in your own way, then the better off you'll be. You'll be more genuine and more real when you're talking to your patient. So you might say, oh, I wouldn't say I'm brokenhearted. I would say more like, oh, that really hurts me that happened to you. And if you take this idea and make it your own, you're much more genuine, and it's going to help. When you speak as an authority, it's hard to connect. So don't say this like a know-it-all. You have trouble trusting because you were abused in childhood. I'm an expert, I know these things, and I'm going to tell you a fact. That doesn't work. They already know this. If you're going to say it sweet like Kate does. She says, of course you have trouble trusting, and she says sweetheart a lot. So she'll say, of course you have trouble trusting, sweetheart. You were abused in childhood. It was horrible. So if you're going to give an idea to a patient, we want that to be personal as well. A therapist being well attuned and using her own feelings to connect and care. That's where we're headed. Attune to your patient. Add in sharing your feelings, and you get the connection that heals. Next, exceptions. This is the next therapy that we integrate. And this principle says, no matter how sick somebody is, they will have moments every day in which they are well. This is what this personality is like. This is how it functions. No matter how well somebody is, they'll have moments where they're sick every day. You can be the wellest person on the planet. Well, maybe there's some totally enlightened gurus in some mountain in Tibet who never are sick. But for all the rest of us, you can be a very well person, and driving home from work, you're tired, someone cuts you off, and you get angry, whatever, and you're not well in that moment. Well, let's flip it. I don't care how sick of a borderline patient you are, every day you're going to have moments where you're a little well. So here's an example. A depressed person has a moment in the afternoon, usually when they've got the blankets over their head in bed trying to take a nap and they haven't been out of the house in weeks, and they'll think, I should call my sister. She's been having a rough time. Now, let's say this person doesn't do that. They just think about it. Even that thinking about it is a wellness exception. It's something that is not what a depressed person does. Think about contacting and helping someone they care about. So, here is the essence of exception-focused therapy. Don't fight the problem, grow the exception instead. So, if that person gave an example to me, if I thought about calling my sister, I would say, wow, what was different about that moment that you thought about calling your sister? I don't know, I just started missing her. Okay. And it sounds like you care about her a lot. I do. I care about her and I miss her, and I know she's having a rough time, and I guess I cared more. So when you care more, you're able to do things that are not what a depressed person does. Yeah, I think you're right. Okay. What else do you care about? Somebody. Well, I care about my cat. Okay. What do you do when you care about my cat? Well, I feed her. So you get up out of bed and feed her. Look, every time you care, you're not being depressed. We can build on that. So don't fight the problem of depression. Grow the exception instead. Now, what you talk about gets more real. So when you talk about the exception more than the exception gets more real. If I take my time and talk about how you care and who you care about and when you care and what you do when you care, I'm not talking about depression. And the depression gets less real and the caring gets more real. If we flip it and I talk about the depression, how was your depression today? When you were depressed? When were you most depressed? What did you do? If I do that, that becomes more real, right? So we're going to talk about the exception. And here we have a woman saying, don't talk about my problem. I want to talk about my exception. The Nysa exception is particular. It is specifically about personality disorder, because that's what we want to do, heal personality disorder. And it is the opposite of the DSM criteria for personality disorder. So there are 7 to 9 criteria for every personality disorder in the DSM. And if you know them, you can look for the opposite of them, right? So I know them pretty well. One of the criteria for avoidant is won't engage in relationships unless they're certain of being liked, right? But an avoidant patient comes in and says, yeah, I had to go to this mixer for this new job I'm on, and oh my God, I was so terrified because I didn't know any of the people and I didn't know if anyone would like me. But you went anyway? I did. Okay. How'd it go? Well, yeah, I really hit it off with this one woman, right? There's an exception. So I get to talk about that moment in that mixer with all those people in which she connected with this person. I get to talk about that instead of talking about her avoidant personality. Examples of the opposite. A borderline person manages their anger, right? That's the opposite of severe troubles with anger, one of the criteria of borderline. A schizoid patient gets angry. That's one of the criteria, one of the features of schizoid personality is really reduced, blunted affect, blunted emotions, especially anger. And they get angry. And we get to talk about how they got angry and say that's wonderful. And with the borderline, we get to talk about how you didn't get angry, and that's wonderful. A narcissistic person never wants to admit fault or flaw, right? And they apologize for doing something wrong, and it's a real apology. The opposite. An antisocial patient makes reparations. They did something really bad, and they come back and they make reparations. An OCPD person, obsessive compulsive personality disorder person, asks for help. They're kind of well known for not feeling they need help from anyone. They're in charge of all their problems. They'll take care of all these. So, if you listen for the exception, it's always there. I swear, if you're a solution-focused therapist, you know this already. You've been trained in this way. If you're not, trust us who know solution-focused therapy, where the idea of exceptions come from. It is always there, but you do have to listen for it. The next idea is the idea that the personality comes in parts. The personality is not a single thing. It has many different parts to it. If you think about it, you are one way with your best friend, another way with your partner, another way with your parents, another way with your kid, another way with the person you work with, right? Now, these can be softened, and that's the sign of a healthy personality, that you're pretty much the same most of the time, but you still kind of are different as you move into different settings, and those are different parts of the personality. And in the two courses, the two lessons that come in this course about parts, you will see that we break it down a lot. We'll teach you exactly what they are. Now, if the parts of a person cooperate, that person is well. If the parts clash with each other, that person is sick. This is a rule, an idea you can hang on to, and it will always serve you. So what are the parts? The parts are the people, in quotes, or the voices, in quotes, that live inside the patient's childhood imagination. The patient can feel them or even hear them. Now, when people have personality disorder, it is because they've been hurt in childhood and they get developmentally arrested or frozen or stuck at a very young age. And what that means is, being stuck at that age, they use their childhood imagination to think about the world. And that childhood imagination, that young child thinks with all these people, all these characters, all these images. That's how they think. And that goes on to be the way that a personality disordered person will think. So, the first part for us is the real self. And this is just our idea of the parts. There are many ways that people think of the parts. Ours is not right. Ours is what works for us in our therapy. So, the real self. The real self is who you really are. Kind of that core feeling, this is who I really am. It's your talents, your deepest feelings, your virtues, your ambitions, your empathy, creativity, your values and morals, your temperament, your soul, your heart. It's who you really are. Look at all these lovely real selves. Look into those eyes. There's real people in there. And an hour from now they'll be hurt. Later they'll be angry. Later they'll be judgmental. They'll go into different parts of their personality. But right now we're seeing those true selves shining through. What does the real self want? The real self wants to activate. Now, what does that mean? It means to come alive and use all the capabilities it has deep inside. That's what we're looking for. That's what Nysa Therapy is all about, helping that real self to activate. Now, where does personality disorder come from? When a young child has too much trauma, all of us have trauma, all children have trauma, but if there's too much in the form of poor attunement to their needs, abuse, physical, sexual, verbal, or neglect, if that is too much, some of the parts of the personality decide it is too dangerous for the real self to activate. And they overpower the parts that are helping the real self to activate. This battle is personality disorder. Parts of me want to help my real self to activate. Other parts of me say, no, You were hurt too bad the last time you tried to be the real you, the real self back in childhood. We've got to stop this. It's a simple idea, but this will work for you guys. This will hold up. You will find that if you keep this in mind, you will understand the personality disorder in front of you. What's the first part that is trying to stop activation? It is the critical parent. Now, the critical parent is mean or even abusive to the patient. The patient can usually hear the critical parent say things like, "You're such a loser, you'll never get that job. No one will ever love you. You stupid bitch, don't go on that date. He's just going to put you down. The world would be better off if you were dead, and so would you." These are real things we hear every day at work that our patients are listening to. That is in the heads and minds and imaginations of our patients. Now, here's the twist. If you think about what I told you about where personality disorder comes from, then you can understand that the critical parent attacks the real self in order to protect the real self by keeping it from coming alive and activating. However weird it sounds, the critical parent is trying to protect the real self when it acts mean. It is trying to scare the real self into not being vulnerable and not living life. It's caring, but in a very twisted way. The next part is the hurt child. And the hurt child is the patient's memory of who they were when they got badly hurt as a child, usually between the ages of about 2 and 7. This part is sad and scared, sometimes mad, but not often. The hurt child wants to go home. To protect the real self, the hurt child split off from the real self when the trauma got bad. Things are really bad at home. There's abuse, there's fighting, there's all kinds of bad things. And this person, this little child, is experiencing a lot of hurt. And they can't function if they live in that hurt all day long. So they split off, and the hurt child comes over here, and it becomes a holder, a container of all that pain, the memory of that pain, and all the new pain that's probably coming, so that the real self can try and get through the day and survive. Now in therapy, the hurt child simply wants to come home and be part of the real self again. The next part is the nurturing parent. It is an internal living image of the primary parent. So this child gets taken care of by the parent and remembers the parent, and in its imagination creates a living image of that parent on the inside. It is kind, it is loving, it is encouraging. It helps the real self to activate. It is based on the memory of the parent as an ally, and I'm going to tell you what ally is in a couple of slides. And it develops out of the all-good parent. So that child says, "Oh, this parent, I love this parent, they're all good, I think they're wonderful," and that develops on the inside. There we go. Look at that. That's how you do it. Now for the ally. The ally is not an internal image like the nurturing parent or the critical parent. It is an actual human being that lives outside of this person, right? But it's the all-good outside person. It's that person you think is so wonderful. When people kind of worship movie stars or singers or that kind of thing. They make them the all good outside other, that person who's always wonderful, And this person from the outside actually helps the real self on the inside to activate. It is kind, loving, encouraging, and even firm sometimes, when that's what the real self needs to keep developing. And now, very importantly for you, it is the therapist position in the patient's personality. So when we sit down with a patient, that patient is going to make us the ally. They are here to get help. And they need us to be that person on the outside that helps them to activate. So very quickly, we become part of their personality as an outside other in that ally position. We're going to help that real self to activate. Love that picture. Look at that kid. That kid feels secure in the world. That kid has an ally in the outside world who's going to take care and protect. And that man that this kid is sitting on is also on the inside of that child in their imagination and lives on the inside. So this man in this picture is both on the outside and the inside of this kid. Powerful stuff, because he helps this kid not only when the kid needs something from him right now, but he helps this kid also when the kid is on his own at school, for example, and he can think about what his dad would do to help him in a situation, if that's a dad. He would think about that and get that help. Now, next we have the betrayer. And the betrayer is not an internal image either. It is an outside person, an actual human being. But it is the all bad outside other. And it blocks the real self from activating. It is aggressive, it attacks, and it sabotages, and it's often the partner's position in the patient's personality. There's our betrayer. Now, you may be thinking, and I hope you are, why on earth would anyone choose a betrayer? Well, we all do it all the time. Those of us with early childhood trauma. We choose people to associate with us who will betray us. Why? Because that hurt child and critical parent on the inside don't want the real self to activate, and they will guide us toward an individual on the outside who will do the betrayal and keep us from becoming vulnerable. So that system of three people, critical parent, hurt child, and betrayer, can do a lot to stop the real self from activating. Now what we're going to find is we do have two systems within the personality. We have the defending system, critical parent, hurt child, betrayer, that stops the real self from activating. And we have the authentic system, nurturing parent, real self, and ally, that helps the real self to activate. What is a personality disorder? A personality disorder is the relationships these six persons, people, voices within the personality have with each other. So the critical parent attacks the real self and says, "You loser, no one will ever love you." And the hurt child sees somebody and says, "Oh, you'd be a good betrayer. I'm going to connect to you." And you, as a therapist, as an ally, come in and say to the real self, Wow, that's amazing what you did. I'm very impressed with you. And the nurturing parent jumps on board and said, I agree, that was great what you did, says that to the real self. And the betrayer says, oh, enough of that. I'm going to stand you up at our wedding. And you'll never want to come out again after that. These relationships moving back and forth are what a PD actually is. And these two systems cooperate with each other, one to prevent activation and one to help activation. Now, I've already talked to you a lot about the self in the form of the real self. And I'm going to tell you a little bit more. In the full lesson we have on the self, I get much more in depth on what the real self is about, what the self is about. But right now I want to let you know that the self protects itself by splitting into two parts, the real self and the hurt child. But the self really wants to activate. It does this split into two parts because the hurt child is a part of the self. This is the Wittenberg principle. This is Mary's idea that there are these two parts, but they're both the self. It splits that way to survive, to protect itself, but it wants to activate fully. The whole time it's struggling with personality disorder, it wants that hurt child to come home so that full activation can be possible. So here we see a little real self playing the violin. It's split off, and now it's also a hurt child and a real self, and that hurt child wants to come home. How do we help? Here's what therapy's about. We help by first esteeming. When we find an opposite to a personality disorder criteria from the DSM, when we find that thing, we know that the real self did it. We know that's true. And so we esteem that real self for finding a way to take action, to exist, to be in a personality that is mostly damaged and dysfunctional. So, that borderline patient comes in and says, oh yeah, you know my boyfriend, betrayer. We went out for drinks and he was just flirting it up with the cocktail waitress. It was disgusting. It was horrible. Now, as the therapist, I might say, well, what did you do? Well, I looked at him and said, what am I doing here with you if this is the best you can treat me? And I got on my phone, punched an Uber, told him I was talking to my friend, said I was going to the bathroom, went out, took an Uber home, left him there. Whoa! It's very creative. But you didn't get angry? Well, I got mean, but not angry. Not angry is still good for you, right? In the past, you would have blown up, right? Yeah, I guess I would have. So I'm very impressed you didn't get angry. I think that is very creative. Yes, mean, but still you didn't get angry. Something really right happened here. Let's talk more about how you pulled this thing off. So I'm going to esteem. I'm going to say, wow, look what you did. I'm going to give them praise, respect. I'm going to lift them up by the actions they take when they find an exception. And we help by empathizing. We might say to this hurt child, I'm brokenhearted that you have trouble trusting because you were abused in childhood. We're going to empathize with our feelings, with I messages. We're going to say, this really hurts me that this happened. But now, are you ready? There are 6 parts to the personality, 3 in the defending system and 3 in the authentic system. And we esteem and empathize every single part. Everybody gets to feel good. Even the parts that seem the meanest and the most cruel and the most horrible, we're going to empathize and esteem those parts. How therapy works. Empathy and esteem break down the old, unneeded protections of the defending system and build up the authentic system. Both of these free the real self to activate. If we've got a defending system and an authentic system, we've got both of those things, and we break down the defending system, all the defense mechanisms it has, if we break that down, well, where does all the energy go that this defending system was using? It goes over to the authentic system. It starts to go there. So that helps the real self to activate. If we esteem and build up that real self and the nurturing parent and the allies they have in the world, if we do that, then they get stronger and that real self activates. We even, if we're in the ally position, will even esteem ourselves. Not directly, but if a patient says, "Thank you so much. You have helped me so much. I don't know how I would have done this without you." Happened for me yesterday. I say, "You are welcome. I'm so glad to have done that for you. And believe me, I've worked hard for you because I wanted to see you get well." So we esteem ourselves even in the context of that therapy, not to get a fat head, but to validate that patient's experience. Everybody gets the goodies. Everybody. Activation is the answer. Once the real self is free to activate, most of our work is done. Not all sometimes, but most. Sometimes the brain is, say, highly wired for anxiety, and we might have to do some CBT to change that particular wiring for anxiety. But a lot of times the activation will take care of that anxiety on its own. If the patient is badly abused, therapy can be long and difficult, but it does work in the end most of the time. Not every time yet, sadly, but most of the time, if we stick with our goal is to activate what's real in your capabilities, where that real self lives and thrives. If we do that, this patient can get well. Here it is, the brief way, the preview of how Nysa Therapy works. First, if you're a patient, you have symptoms. That's the only reason you come in, is because you have symptoms. So a patient walks in, they have symptoms. We know that the symptoms are the defending system attacking the real self. We know that. We know the defending system attacking the real self is an obsolete survival method. It's a way this child had to survive when they were being hurt, and it persisted, it lived on into adulthood. But now, in therapy, it's thrive time. It's not survive time anymore. This is just us. This is how we do things. We do not help people cope. We do not help people manage symptoms. We want to see them activated and thriving, not just finding better ways to survive. That's how we do things. How do you thrive? With exceptions. If caring is a way that you're not depressed, let's go back to caring over and over again. Let's get more caring. Let's build it up. Let's esteem it. Let's help it thrive. And if that caring thrives, eventually it starts to take over the personality. That real self takes over. and the old obsolete survival methods are no longer needed. How do we help exceptions to thrive? Through our feelings. We attune to the patient, we share our feelings, and we connect deeply with them. And that either breaks down the old system or it builds up the authentic system. So, through connection, we get to have empathy for the pain our patient goes through and esteem for the exceptions they generate. Through our connection, I'll say it again, we get to have empathy for their pain and esteem for their exceptions. Empathy plus esteem equals a breakdown of the defending system and an activation of the real self. And now, the shortest just say it we could come up with about what Nysa Therapy is all about. Empathy plus esteem, break down the defending system, and activate the real self. That's the end. And thank you, Kate, for looking at me a long time ago and saying, just say it.